Good evening, everyone. My name is Gabriele Colasurdo. I'm the Manager of Education and Patient Services here at Myeloma Canada. And welcome to tonight's webinar on high-dose therapy and autologous stem cell transplantation. Our presenter tonight is Dr. Hira Mian, a hematologist from the Juravinski Cancer Center and assistant professor at the Department of Oncology at McMaster University in Hamilton. As you know, high-dose therapy, or as you may know, high-dose therapy and autologous stem cell transplantation is sometimes referred to as a stem cell transplant or a bone marrow transplant. And it's the standard of care and most commonly used therapeutic approach for newly diagnosed transplant-eligible patients with myeloma. Before we get to Dr. Mian's presentation, I'm just going to go through a few things. So I want to let everyone know that all of our presentations are recorded and they're uploaded onto our YouTube channel. So if you missed something, don't worry, you can always go back and re-listen to the presentation. In order to do that, in a few days, if you go to youtube.com and type in Myeloma Canada, you'll see the first search result that you get is our Myeloma Canada page. If you subscribe to the page with this button, you'll get a notification every time we upload a new video. And when you click on that, you'll be able to find the latest uploaded video. There's another way to get there, and it's from our website. If you go to our website, myeloma.ca, and you click on the top tab, Resources, this drop-down menu will show up, and you'll see the educational videos link here. You click that and it'll bring you to the YouTube page. Now, finally, I will take questions during the presentation. You can type them in, and at the end of the presentation, I will read them to Dr. Mian, who will answer them. And now, so the way that you can type in your question at any time, if you just locate the software that the webinar is running on, your GoToWebinar, there's a little panel here that says questions. If you click on the little arrow, it'll open up, and you can type your question here. Once you click on the button Send, I will receive the question, and then I'll be able to ask it to Dr. Mian. And there's the send button, yeah. So without further ado, I would like to welcome Dr. Mian. Dr. Mian, thank you so much for joining us tonight and agreeing to this presentation.
Perfect. Thank you so much, Gabriel. I'm really excited to present this topic to everyone that's online. And then hopefully we'll have some time to answer questions at the end. So I hope everyone can hear me okay. So I'll just move on. So as Gabriel mentioned, the topic we're going to discuss today is high-dose therapy and an autologous stem cell transplant. So Gabriel, I'm having a little bit, did you advance the slide for me? Okay, let me just make sure that the slides are working. Okay, perfect. Now I have control of it, I think. So just before we get started, in terms of my conflicts of interest, you know, I've been on advisory boards and received honorariums from different drug companies. However, today we're not talking about any of these particular drugs, and my presentation otherwise is not influenced by any of that. So in terms of the outline of the presentation, you know, so I'm going to spend the next 30 to 35 minutes first talking to you a little bit about really going back to the basis. I think as you get diagnosed with myeloma and as we start to, you know, talk to you about stem cell transplant, there's a lot of terminology that's thrown around that's often quite confusing. So we're going to review that briefly in terms of what stem cells are, what bone marrow is, how plasma cells relate to that, and then where does myeloma fit in with all of that. And then the bulk of my presentation will really be about process of stem cell transplantation. And it's going to be really a practical approach in terms of what happens on a day-to-day basis and what do you expect as you go ahead. Some of you, you know, may have already undergone a transplant or be preparing for one or ultimately be caring for someone who's going to undergo that. So hopefully we'll be able to cover various aspects of that. And then lastly, there will be hopefully some time for questions, and I'd be happy to answer any of them. So I think we talked a little bit about some additional resources or the YouTube channel, but a lot of what I'm talking to you about today is available in an info guide, and that again is available through the Myeloma Canada website. You may also be getting this information guide at your hospitals or from your physicians as well, in addition to local information as well. So a lot of this material you can review both in the info guide and again, I guess also on the YouTube channel. So the first part is just going back to the basis. So stem cell transplantation, before we even talk about what it is, I think there's a lot of confusion about what a stem cell transplant is. Some of you may have had other friends who've had transplants or other relatives, but we have to remember there's actually different types of stem cell transplants. So just because your friend or a relative has had one, you may be getting a different type of it. So there's two main different types. One is called the autologous stem cell transplant, where the stem cells really come from yourself. So we take your own stem cells and then put them back in you. There's another type of transplant called an allogeneic or a donor stem cell transplant. And in that, stem cells actually come from someone else, whether it's a sibling or an unrelated relative. In terms of the difference, as I briefly mentioned, between an autologous and an allogeneic transplant, it's really autologous that we'll mostly be talking about today. Autologous transplant, where you get stem cells from yourself back into you, is really the most commonly used therapeutic approach in patients with transplant-eligible myeloma. Allogeneic transplant, I'm really not going to be talking to you much about that because it's really not a standard of care, and it's really done in a very selected few number of patients throughout Canada for particular reasons. So today, the bulk of our conversation will be about autologous stem cell transplant, which is really what most of you will have either undergone or be undergoing. So now a bit about bone marrow. I'm sure that most of you have had a bone marrow, and that was initially done as part of your diagnosis. But a bone marrow is really the spongy tissue that's found inside your bones. It's where most of your blood cells are made. It's actually present in a number of different long bones, but the most easy place to access it is in that pelvic bone, where we would have done the initial bone marrow to make a diagnosis of multiple myeloma. This idea of stem cells. Now, stem cells are found in the bone marrow, so that's where they actually live. And the cool thing about stem cells are that they can actually grow into different types of blood cells. So a stem cell is a precursor cell which can turn into white blood cells, which can help you fight infection. It can turn into red blood cells, which ultimately carry oxygen and give you energy. Or it can turn into platelets, which stop you from bleeding and help blood to form clots. How does a plasma cell fit into all this terminology? So a plasma cell is a type of white blood cell. So it's a normal cell that really everyone has in their bone marrow. And it's in the normal patient, it's present in a very small quantity. It's still really important because what it does is it produces these things called antibodies, which help you fight infection. What myeloma really is an abnormal growth of these plasma cells. So there's a picture of a plasma cell that I put down. So, everyone will have 3 to 5% plasma cells in their bone marrow, but in myeloma, what happens is that these plasma cells become cancerous. And instead of being in low numbers, they actually take over your entire bone marrow, and that's some of the damage that it causes. So multiple myeloma is a cancer of these normal plasma cells that just grow too much in your bone marrow. It can cause a number of different health problems. So a multiple myeloma can produce this M protein, which is an abnormal antibody, and that can interfere with your ability to fight infections. It can also crowd out the bone marrow and stop other cells from being produced. And at the same time, it can affect the bones and cause fractures and cause calcium to be released from them as well, which is part of myeloma. So hopefully that sets us up a little bit in terms of terminology. So stem cells are made in the bone marrow, and a plasma cell is a normal cell, but in myeloma, it becomes cancerous, and that's where the side effects of multiple myeloma really come from. So the next part of the talk is going to go over the process of stem cell transplant. So as I mentioned, I'm only talking to you about an autologous stem cell transplant. I think before we talk about the different steps of it, I just want to clarify what the purpose of a stem cell transplant is. So we really want to give you a stem cell transplant because we think that we can give you high dose chemotherapy with it. So the purpose of the stem cell transplant is that I'm able to give you really high dose chemotherapy, and then if I wasn't going to give you your stem cells back, your blood counts would remain low for a really long time. So by giving you your own stem cells back after we give you this high dose chemotherapy, the blood cells will form quicker and you'll go back to leading a normal life quicker. So the point of an autologous stem cell transplant is in order for us to deliver you high dose chemotherapy, and I'll be talking about that in the 7 steps of transplant. So first, before we decide whether or not someone is going to undergo a transplant, we think about whether they're eligible for a transplant. So this decision actually often happens right at diagnosis before you start, your CyBO-D or any of your chemotherapy. And so there's a number of different ways in terms of how we determine eligibility, and I'll be talking about that in the next few slides. The next part prior to undergoing a stem cell transplant is induction chemotherapy. So we want to bring your myeloma to a little bit lower levels before we actually do the stem cell transplant, and that's done through induction chemotherapy. The third step is, if we decide we're going to do a stem cell transplant, well, we need to get the stem cells out of your bone marrow and into your bloodstream. So hopefully that will lead to step 4, which is collection of your stem cells, which is often called a stem cell harvest as well. And again, I'm going to be going over each of these steps in details. The next part, which I think is actually the most important part of the stem cell transplant, is that delivery of high dose chemotherapy. And the purpose of that is to kill as many of the myeloma cells that have been left over even after we did the induction chemotherapy. Then we rescue you with your own stem cell infusion. So that's where the stem cell part of it comes in. We give you the conditioning high dose chemo, but then the rescue is with these collected stem cells back to you and to tell them to go back to the bone marrow and start producing those cells. And that term is often called engraftment. There's a long recovery period from the time you get the initial high dose chemotherapy and the stem cells until the time you reach engraftment, when your blood cells all come back to normal levels. And even for months afterwards, there's a long recovery period in terms of really getting back to your normal quality of life. So I'll be talking about each of these steps in a little bit more detail. So the first step is, how do we decide if someone's going to be transplant eligible? And really, that's quite a complex question, and there's no great algorithms about how to do that. Overall, if you have a good health status, you don't have any major, health conditions, and you're otherwise fit, we would likely be considering a stem cell transplant. Now, the aspect of age is a little bit complicated sometimes because although, someone may be 71, they may actually be a really fit 71, and a 64-year-old person may in fact be a frail 64-year-old person. And that's where a little bit of clinical judgment comes in, because a stem cell transplant is a complicated procedure which does have complications. So we want to ensure that if we're going to offer it to patients, that it's the absolute right decision for them. And so part of figuring that decision out is determining who can undergo this difficult procedure and actually have good outcomes from it. The eligibility criteria, again, differs a little bit across the country and a little bit across physicians as well. So the next step is, if we decide, we think this patient is good for a stem cell transplant and we think we can tolerate it, let's try to bring their myeloma cell numbers down a little bit prior to doing that procedure. So the way we do that is through induction chemotherapy. And often that's chemotherapy that you get for about 4 to 6 months. And the most commonly one used in Canada is CyBO-D. And that's what most of you may know it as. It includes oral pills called cyclophosphamide, the subcutaneous injection called bortezomib, and again, oral pills called dexamethasone. So often we use this kind of on a weekly schedule for about 4 to 6 months to try to bring the myeloma number down a little bit before we collect your stem cells. Induction chemotherapy, so Cyborg-D chemotherapy, has a number of side effects. It can cause fatigue, mouth sores, some stomach upset. It can lead to clotting or low blood counts. Again, specific drugs have specific side effects as well. So things like neuropathy, numbness, or tingling, it happening in your extremities can also be a complication of this. I think one of the most important things is that if you're experiencing any side effects, please let your healthcare providers know, because there's often a number of things that we can do with the chemo itself. Sometimes we can spread it out, we can change the doses slightly, and you may still have fantastic myeloma control. So if you're having some side effects, even if they're minimal, let us know so we can follow it along and treat them appropriately. This idea of chemo brain or a fogginess is well described by a lot of patients, and unfortunately I think we often don't spend enough time talking about it. But the idea that you're forgetting things more, there's periods of confusion, or you're having difficulty concentrating as you undergo any type of chemotherapy is very difficult. Again, those are all things that you need to discuss with your healthcare provider, because there may be some strategies that we can put in place. There's no real treatment guidelines about this, but there may be some coping strategies like having memory aids, making sure that your medications are in a blister pack, that you know the timing of it, that there's a good support system around you that we can try to incorporate in order to minimize or manage some of these side effects. So once you've gone induction chemotherapy, which is often that Cyborg-D chemotherapy for 4 to 6 months, we try to determine what's your response like. Have you responded at all to chemotherapy? And often that means that you've had some form of a reduction in your myeloma cells or in your myeloma protein. And that often there's somewhat of a threshold about what we decide is good enough for us to go ahead with transplant. And usually we like to see at least a 50% reduction in some of your myeloma parameters for us to be able to go ahead with transplant. And the reason is just that if you're having a response to chemotherapy with the Cyborg-D, that's a good indicator that you probably are going to respond to the high dose chemotherapy that we give you with your transplant as well. So as part of getting transplant, you got the induction chemotherapy, you tolerated the side effects, your response was adequate. Now things get into motion about the actual stem cell transplant and the preparation around it. So hopefully by this time, you've already met the transplant coordinators, you already know the team, a schedule is starting to be developed. And so some of the things that you'll undergo as in preparation for stem cell transplant is a central line. And that's really a large IV catheter that's put in often in your upper chest. And it's often put in by interventional radiology under local anesthetic. And with that, we can safely do both the stem cell transplant and collect the stem cells as well. Often some patients describe a little bit of discomfort at the chest wall where it's done. This is a temporary line. Eventually it will come out a number of weeks after the transplant is done, but it does require some care as well to ensure that you're not lifting heavy things or that it's kept clean, and there's a flushing protocol often associated with it as well. So your team would have initiated that as well at the time of central line insertion. So once the central line is in, the next step is, all right, we need to get those stem cells. So there's a procedure called a stem cell mobilization prior to getting the stem cells out. And the idea with this is, well, all these great stem cells live in the bone marrow. How can we convince them to come out into the bloodstream so we can actually collect them? And there's two main ways, and I would say actually one common way in which we do it is by giving you GCSF, or what's called Mupagen. What it really is, it's these it's these subcutaneous injections which tell your bone marrow, release all of these stem cells into the bloodstream, so eventually we can collect them. Most often you'll be getting G-CSF or Neupogen as a way to collect stem cells, and rarely in circumstances do we use a chemotherapy called cyclophosphamide as well in order to collect those stem cells. Both of these agents that we use to get your stem cells out of your bone marrow so they come out into your bloodstream and we can actually collect them have some side effects. With G-CSF or Neupogen, one of the most common side effects that we see is this bone pain. And that often happens, somewhere in the middle of the treatment. So if you're getting it for a few days, it may happen in the middle of it. And it's often when the stem cells are coming out. Now, some people really experience it and some people find it quite difficult, and some people don't, it's not a problem at all. But the important thing is just to have a plan around that, because the last thing you want to have is at 3 a.m., you're having a lot of pain, you don't have any pain medications, and there was no plan in place. So when the G-CSF injections are prescribed to you for stem cell mobilization, make sure that there's a plan for what to do in case you do experience that bone pain. Cyclophosphamide is really not commonly used anymore for stem cell mobilization, but it's high-dose chemotherapy and often has a number of side effects associated with any type of chemotherapy, such as nausea, general weakness, loss of appetite, and can also affect and can also potentially cause a rash. In terms of harvesting the stem cells, so after we've mobilized your stem cells, convinced your bone marrow that release those stem cells out into the bloodstream, the next step is actually collecting them. So this is actually it's a long procedure, but it's a relatively straightforward procedure. It's called a leukapheresis, where stem cells are actually taken out of your normal bloodstream. We're not going back into your bone marrow. And you sit next to a machine, which often looks like a big dialysis machine, for a number of hours. So make sure when that happens, you bring a good book or a good friend with you, because it can become quite boring. So you're sitting with this machine and the stem cells are being collected into that machine. And often there's a minimum number of stem cells that we need in order to successfully do a transplant. And often, we check at the end of the day if we have enough stem cells. If we don't, we may need to call you back in for a subsequent day. So as I said, harvesting stem cells is done through this a peripheral blood source. So it's done, through a normal IV that may be collected to your central line, and you're sitting with this big machine where all of your blood is being filtered and the stem cells are being collected. While you're sitting in that machine, next to that machine, some of the common side effects that people feel is that they can get cramping or a tingling sensation. And the reason for that is that there's your blood is mixed with an anticoagulant just to ensure that it doesn't clot as it's going through the machine, and that can affect your calcium levels. So if your calcium levels drop down low, you may get cramping or tingling or some neurological signs, but the nurses know about this. This is a common side effect, and they already either are running a calcium infusion or may give you oral calcium tablets as well to manage those side effects. So a very manageable side effect. All right, so once we mobilize it, we've collected those stem cells, the next step is we need to freeze them. And the reason is because even though we've collected your stem cells, we're not using them right then and there. We're going to use them in a few weeks and potentially in a few years as well, because sometimes you may be collected for a stem cell in the future as well, or in what we call in a salvage setting as well. So stem cells need to be frozen in order to ensure that they're still going to be usable. And they're often frozen in this chemical called DMSO. And what that does, it prevents the waters in the cell from forming ice and permanently damaging these cells. So as I mentioned, often, even though you'll be getting a stem cell transplant in the upfront setting, we may be collecting for more than one transplant depending on what the plan is. The idea is that, stem cell transplant or stem cell harvest, if we're going through that procedure already and doing the mobilization and doing the collecting, if there's ever an option of doing another stem cell transplant in the future, we might as well have collected the cells. So it's common practice to collect enough stem cells for 2 transplants. So now you've had your stem cells mobilized, you've collected them, they've been frozen. Then the next step is a decision is made about whether the transplant is going to be done as an inpatient or as an outpatient, and there's multiple factors that are associated with that. And so whether or not you're admitted or not, the next part is giving you that high dose chemotherapy. And that's really the whole reason we've gotten to this point and are actually doing the stem cell transplant. So with this intravenous melphalan, and that's this high dose chemotherapy, it's really the strongest type of chemotherapy you would have received so far. The idea of that chemotherapy is just to blast your bone marrow and get rid of any myeloma cells that are anywhere in your body. So the induction chemotherapy, the CyBorD, hopefully already brought you down to a lower level of myeloma cells, but with this high dose chemotherapy, we can further bring down that level of myeloma cells. So often when you get this chemotherapy, we encourage you to often chew ice chips to try to prevent later on mouth sores from happening. So once you've had the high dose chemotherapy, that's it. It goes in, nothing happens that day. The following day or about 24 hours later, you get those stem cells back. And that's just to say, the reason for that is, the day before we blasted your bone marrow with pretty high dose chemotherapy. And then today we want to put the stem cells back so the bone marrow can start to be rescued and start to recover. And the idea is that once we put those stem cells back, that they'll go back into the bone marrow and start producing those white blood cells that we need to fight infection, those red blood cells, as well as the platelets that we need. Stem cells are often infused, either they can be done with a hanging bag or at some institution, a physician physically pushes them in. And so there's different protocols at different sites. As the stem cells go in, because they're in this preservative called DMSO, you may experience some side effects. Common side effects include nausea, vomiting, or abdominal cramping. Some patients do end up throwing up, and that's totally fine. It's again really that preservative that the stem cells are frozen in that causes those side effects. There's also a very particular smell that's associated with it. And so some people say it's like a garlic or a cream corn. You may not smell it that well, but definitely the people around you will be able to smell it for the next 24 to 48 hours as that preservative goes away. Rarely can you have more side effects when the stem cells actually get infused, such as low blood pressure or a fast heart rate, but that's why there's a physician going to be close by as the stem cells are infused. All right, so with this whole procedure of high dose therapy and then putting the stem cells back in you, there's a number of side effects. Nausea, vomiting is a big one, and again, we have really good drugs to be able to manage that. So if you're having that side effect, let us know, and there's multiple drugs that we can add in. Getting mouth sores or dry mouth is a common side effect as well, and sometimes you may need additional pain medications for that or a mouthwash. That can sometimes even affect your ability to eat, and you may need a dietitian or additional nutritional support. Again, you'll have some altered taste, smell, and loss of appetite. Fatigue is a common one, and you're not just going to have that fatigue for a few weeks. That fatigue can linger on for a few months post-transplant. Hair loss is again another common one that will happen about 2 to 3 weeks after high-dose chemotherapy. There's also some potential long-term effects of high-dose chemotherapy, such as secondary cancers. Every time we give you high-dose chemotherapy, additional cells can be affected, but that risk definitely outweighs, that benefit outweighs the risk, and therefore we do think that it's worth it to undergo a stem cell transplant. Again, we're watching for additional organ damage in the long term, although those risks are really low. Infertility is again a potential problem as well, although a lot of the patients that get a stem cell transplant, it may not be a concern. So the recovery period of a stem cell transplant can be done, again, as I mentioned, as an inpatient or an outpatient, and you'll be monitored really closely. Someone will be examining you as well. And there's often a multidisciplinary team that takes care of you, a doctor, a nurse, a dietitian, a nutritionist, a physiotherapist, depending upon what your needs are. And as you go through this recovery period, one of the most common side effects is actually an infection. So we're monitoring you closely for an infection. And sometimes that infection, can be bad enough that we may have to get it, you may have to go to the ICU, or that we may need to provide you with additional support. But that's why you're being monitored very closely for those things. It's important to eat and stay active during your recovery. So as much as you can, try to get out of bed, try to walk around a few times, make some new friends if you're admitted at the hospital. And again, this is saying somewhat of what I've said previously as well. If you're having side effects, let us know, because often we can manage them, So if you're having any fevers, chills, or a cough, we definitely need to know, because we need your blood cell counts drop down pretty low afterwards. So we need to ensure that you're getting the appropriate antibiotics. Because you have that central line in place, you're at risk of getting infections around that line as well. So we need to make sure that that looks okay. And then because, your platelets, which help you clot, can drop down low, you're at risk for bleeding as well. And often you may actually need to get platelets or a blood transfusion during your transplant course. And I think I've covered some of this. Depending on, your blood results, you may need a blood transfusion, you may need some more hydration. We may need to do some additional tests to look for an infection, and giving people intravenous antibiotics is very common during a transplant course. Some special precautions that you can take are, I would say, hand washing is probably the best one. Make sure that you're washing your hands with soap and water, and that if there's anyone who's really sick, such as a family member, they may not want to come visit you during that time. Make sure you're otherwise showering, keeping clean, and that's pretty much, the hand washing is probably the most important precaution that you can take. Additional things that you can do is, don't floss, use a soft toothbrush, and that your blood counts are low, so you're at risk of bleeding. And again, don't use things like razors or scissors, because they, again, can lead to increased bleeding because your blood counts are low and put you at risk of infection. A dietitian and what you're eating and how, if you're losing weight or what that course is often followed very closely by the transplant team, both for the first few weeks and also long term. And we may need to get a dietitian involved in that as well. So we've just put down some general things about when to call a nurse, whether you are having a transplant as an inpatient or outpatient. But if you're having a lot of pain, if you're having a lot of mouth sores, if you're having any nausea, vomiting, again, we can help manage that with a number of different types of medications. If you're having constipation or diarrhea, again, we can help you manage that. If you're developing more serious side effects, as any shortness of breath or any problems with your central line, please let us know as well. If you're having trouble taking your medications, let us know as well, because there may be an opportunity to switch you to some IV medications. In terms of emergencies, I would say fever is a big one, and that's not just after you've had the transplant. Even in the days when we're preparing you for a transplant and waiting to collect your stem cells, it's really important for us to know if you have a fever. Again, if you're having any chest pain or trouble breathing, or having any diarrhea, or really having any severe nausea or vomiting at any point, those are all indications to let us know. So once you've had this procedure, you've had the high dose chemo, you get the stem cell transplant, you get the stem cell infusion the next day. You hope that all the stem cells go back into your bone marrow and start to produce the cells. It often takes about 2 to 3 weeks for your blood counts to come back to normal levels. And that's when you're at the highest risk of those infections. But once those blood cells come back to normal levels, a lot of your symptoms start to improve. So this idea of when the blood cells all come back to normal level is called engraftment. And often we're waiting for your white blood cell to come back to a somewhat of a normal, or at least get to a certain level. And then we're also waiting on your platelets, which help you clot, to get to a certain level. After you've had this entire procedure of the high dose chemo, the stem cell transplant, you've gotten through the 2 to 3 weeks until engraftment, you're back home, you're still quite tired, but you're slowly starting to recover. At some point, your physicians will then talk to you and reassess your disease response and say, well, you've had a great response to transplant, you've tolerated it well, and now how can we keep the myeloma away for much longer? So we'll often talk to you about a maintenance therapy pill that's often Revlimid or lenalidomide, which is the same pill, or it may be a different maintenance pill as well. It's often started about 3 months after stem cell transplant, and it can really help your overall outcomes. But we're not going to be talking to you about this well until you're feeling a little bit better, your blood counts are better, and up until a few months after transplant. When that conversation of maintenance therapy happens with you, there's a number of things to consider, and your physicians will at that time talk to you about some of the risks, such as the increased chances of potentially developing long-term other types of cancers as well. Oh, all right. And so that's pretty much what I had in terms of a nutshell about stem cell transplantation. Stem cell transplantation really remains an important part of the myeloma treatment. It has been shown again, even with all of the fancy drugs that we have right now, that it's a cornerstone of myeloma treatment, and that it can really help us put the disease away and keep it from coming back for a much longer time. Stem cell transplant doesn't cure myeloma, and I think everyone needs to understand that. So just because you have had a stem cell transplant doesn't mean you're myeloma free. The myeloma will always come back, but hopefully it will come back after a much longer time. This is really a team process, so multiple people are involved in that from a healthcare perspective. So you'll have your physicians, your nurses, your transplant coordinators, and it often feels quite overwhelming. But there's multiple sources of information, and hopefully, you'll have access to both of them at the hospital which it is happening. And then you've also had additional resources as well, such as some of the resources provided to you by Myeloma Canada. And if you're ever confused about anything, just ask again. This is complicated stuff. Just the calendar alone of a transplant is so complicated. So we're happy to go over it with you again and again. So don't ever feel like, it's confusing. It is confusing, but help us help you figure out and get your questions answered so you feel more comfortable with the information being provided. So that's pretty much all I had, and I'm happy to take any questions at this time.
Thanks. Thanks so much, Dr. Mian. That was a lot of information, a lot of information to digest. And as you mentioned, there are some resources available where you can go over this information again. So I did get a few questions, and so we can start with that. So the first question has to do with a potential side effect. Now, having something like itchy hives on your face, is that something that's common that could be related to a stem cell transplant?
So because with a stem cell transplant, we're adding so many different types of medications. So it's hard to know, it can certainly happen, but it's hard to know what the cause of it may be. Right, as part of stem cell transplant, you're getting the high dose chemo, then you're getting the stem cells, which have the preservative, then you're getting anti-nausea pills, you may be put on antibiotics in a preventative fashion, you may be put on additional medications to prevent nausea, vomiting. So getting hives or itchiness often means it's an allergic reaction, but we would need to figure out what it's from. and what the cause of it is. So certainly let your healthcare providers know, and it's a pretty manageable side effect. So we can either figure out exactly what the cause of it is and help you manage it as well.
Okay, thank you. The next question has to do with engraftment. So once you're going through recovery and engraftment has happened, could the person potentially travel during that time?
So it takes about, at least let's say about 10 to 14 days or sometimes longer for engraftment. So definitely prior to that, it's not advised that you travel at all. In fact, you're going to be seen daily at the hospital if you're not admitted. Your blood cell counts prior to engraftment, your white blood cell count can really go down to 0. And therefore, that's when you're at the highest risk of infections and mouth sores and diarrhea and not feeling well. So I wouldn't advise traveling prior to engraftment. Once engraftment has happened, we need to make sure that all of the blood counts are stable. It's not just your white blood cell count. Your platelets have also engrafted, so you're not at a high risk of bleeding. And then after that, depending upon, what your recovery status is, how you're feeling, you're going to be pretty exhausted in that first month, even after you've been grafted. So it's just, we often follow patients a little bit closer during that time. But after that, if your energy is feeling better and your healthcare providers otherwise don't have any concerns, there may be a potential to travel.
Okay, great, thank you. The next question comes from someone who's had a transplant approximately 10 years ago, and they didn't really receive CyBorD, and they're really asking, is it because it wasn't available? It wasn't available 10 years ago, or how new is the use of CyBorD in transplant?
So I think CyBorD in transplant, I think it's been used kind of since 2013, 2014. But the fact that, this particular patient has gotten 10 plus years out of a transplant is fantastic. It doesn't, the most important thing is the drug that you get during the time of transplant, and that's called melphalan. That's the same drug that we've used for over 20 years. So that drug was the same drug as we use currently. So that's probably where the benefit of the transplant in that context came. Okay,
great. Thank you. So the next question has to do with the collection of the stem cells. So usually, when possible, I believe enough stem cells are collected to do 2 transplants. And so the question is, how long is the second unit of stem cells frozen for? Is there like a time limit? Is it safe to assume that they will be used at a second time? And if so, at what point would they be used?
All right, so great question. So when we save the stem cells, we often can save them for many, many years, right? They're saved in the freezer. And so if you can use them for many years afterwards. The decision about whether you're going to undergo a second transplant depends upon how much time the disease was able to stay away from your first transplant. So let's say we collected you for 2 stem cells, but unfortunately the disease came back 6 months after your first transplant. In that case, even though we have that second bag collected, it's really not going to be that useful because we know that the stem cell didn't give you as much time as we wanted for the disease to stay away. But let's say you're in a scenario where you got a stem cell transplant, we got a lot of cells, we froze half of them, and now you've had 5-6 years where the disease has stayed away, and now it's starting to come back. Well, in that scenario, we can probably go back to that bag in the freezer of stem cells. We will always retest it to make sure that the stem cells are still working. So the longer they stay in the freezer, you might lose some of them. So we always need to retest to make sure that they're still viable. But if they're still viable, we'll go ahead and use them. And so they do always stay in the freezer for quite a number of years. And whether or not we use them again depends on how your response was often from the first transplant.
Awesome, great. The next question, so we have quite a few, I think we still have some time here.
Yeah.
So the next question has to do, we did discuss a little bit about secondary cancers. And so the question is, what measures can and should be done to determine if a secondary cancer is present or not?
So the risk of secondary cancers happens every time we give you chemotherapy. And the reason is because chemotherapy can cause a lot of other side effects in a lot of other cells. So there's always that theoretical risk, but that risk is actually quite low when you compare to the benefits of giving you chemotherapy and the benefits of giving you transplant. So often we don't really recommend any specific measures to monitor you for secondary cancers. We often just say, make sure that whatever your local guidelines are for cancer prevention, that you're following them. So good things like don't smoke. If you're supposed to get a colonoscopy, get it done on time. If you are supposed to get a mammogram, get it done on time. But apart from regular measures that are endorsed for the general population, we don't recommend any specific measures.
Okay, awesome. So another question that we have here is how many days do you get how many days are there in between the GCSF and the stem cell collection?
So often if we're using GCSF alone, we use it for about 5 to 7 days prior to the stem cells being collected. So often you get an injection kind of every day for about 5 days, and on the 5th day the stem cells are collected, and we may need to use GCSF for a few more days if we don't get the number of stem cells collected. But that GCSF schedule again can range between 5 to 10 days depending on if we're using cyclophosphamide with it as well.
Fantastic, fantastic. So this question has to do with diet and exercise after a stem cell transplant. How important is diet and exercise? But I think I'm going to open up the question and kind of just ask you, even before the stem cell transplant, how important is diet and exercise?
So I think, if you're definitely having a healthy diet, going into a transplant as strong as you possibly can helps you recover faster. So, if you already have good mobility and you already have, you're exercising or you're fit, then you're going to probably recover from that transplant faster. So we definitely encourage you to always have a healthy diet and stay as active as you can. Now, during the time when your blood counts drop so low and you're having a lot of symptoms, there are going to be some rough days, and in those days, it's hard to really try to push yourself. But whatever you can do is worth it. So during those times, if you can walk a little bit, sit up in a chair, whatever you can do is good for you. Definitely afterwards as well, trying to make sure that your weight stays the same and that you're able to get back to some form of, just being active is really helpful, because I think it helps you recover faster.
Mm-hmm. Thank you. Next question. Between collecting of the stem cells and the actual transplant, what's the average person? How will they feel? Are there a lot of side effects during that time, or is in general, do people generally feel okay during that time?
People generally actually feel well during that time. So sometimes there's a number of weeks where we've collected the stem cells and then we're waiting to either admit you to do the transplant. During that time, you're often not getting any chemotherapy or any treatment. And so, you're actually feeling quite well during those days. So that's probably a good time to, kind of socialize, do things. It's a good time.
Great. I guess that goes great with the next question that I have here, and the question is simply: is there a current wait time at your institution for a stem cell transplant?
At my institution, specifically at the Juravinski Cancer Center, we are able to do a transplant somewhere after 4 to 6 cycles of induction chemotherapy. and we're always able to fit people in around that time.
Okay, great to hear. This next question, I think this is one that you get a lot, and so how, we're talking about what's the average amount of time that someone after going through a stem cell transplant will be in remission before the myeloma comes back.
So that depends on a number of different factors. It depends on what your genetic risk factors were. It depends on what your staging may be. We hope that with the transplant, the myeloma will stay away for a number of years. I think one of the things that can help increase that number of years is actually being on maintenance treatment. So if you put yourself, if you are on maintenance treatment like Revlimid, your cancer may really stay away for much longer than if you were not on maintenance treatment. So I think it depends on a number of different factors, but we really hope that in an ideal situation, it will stay away for a lot of years, but there is a lot of variability in that depending upon how aggressive your disease is.
Okay, great, thank you. So yeah, I have a few more questions here, and we still have just a little bit of time. I'm just going to filter through this one here. They're coming in fast and furious. After a stem cell transplant, how long should someone wait before starting high impact physical activities like weight training or cycling?
So that depends. One, you need to really ensure that for heavy exercise that your blood counts are perfect. So the platelet count, which helps you from, which stops you from bleeding, you need to make sure that that count is really good prior to doing any strenuous physical exercise, such as weightlifting. The other thing I just want to mention in this is that, a lot of patients with myeloma may have abnormalities of the bone or may not have the strongest bones, or so there's a number of things to consider in that. I would say, you should probably do as much as you feel comfortable doing and as much as your body is allowing you to do. So, if your blood counts are fine and you're feeling fine and you're not fatigued and otherwise, your bones are good and you're feeling comfortable, then you can probably start to engage in it, but try to go slowly and increase up, just to ensure that you don't have any side effects.
Okay, great. The next question, in someone who's had a first transplant and the myeloma has stayed away for quite a number of years. Let's say, for example, this person has been in remission for about 10 years with the myeloma, but at the time that the myeloma comes back, they're in their 70s. Would a second transplant be considered at all, or is it kind of a it's just not an option anymore once they're above 75 years old or something like that?
It's a really good question. In someone who's gotten 10 years out of a transplant, I mean, that's very rare. That would be an extremely exceptional case. In that case, I think there may really be good consideration to think, well, even if the second transplant gives me half as much as the first transplant, that's still 5 more years. So it would definitely be worth considering. As I say that, I do want to add in that for myeloma, there's been fantastic new therapies that have come on in that second line space. So it will come down to a number of different factors. If that patient is in good health, if the stem cells are saved, if they don't have any other heart problems or lung problems, and if they're otherwise fit, it can definitely be considered in a 70-year-old to think of a second stem cell transplant.
Okay, awesome. The next question has to do with someone who has high risk disease, and they've so far had a great response. They're asking about tandem transplant. So would a tandem transplant, so that would be a second transplant after the first, I guess you could explain it. Is that useful for high risk patients?
So a tandem transplant, I didn't touch on that too much, but it's when you have two back-to-back same types of transplant within 6 months of each other. that has been shown to be effective in certain patients, and certainly in patients with high risk disease. So, a lot of institutions within Canada still tend to do a tandem transplant. That is our practice at the Juravinski, and also concurrently the practice at Princess Margaret Hospital, that if you have high risk genetics, that really we know that you have a myeloma that's not a well-behaving myeloma, and so hitting you back to back with 2 transplants will maybe put your disease farther down and prevent it from coming back in a much longer time period.
Great. Now another question here. So we still have about 5 minutes if you're still okay.
Yeah, no, I'm totally okay.
Awesome. So the next question, someone is asking about, once after a stem cell transplant, someone who's on maintenance therapy, they're asking about naturopathic treatments. Now, is there any evidence that supports naturopathic treatments and myeloma?
So I'm not aware of any evidence, but to add in, I'm also not an expert in naturopathic medicines. I think one of the most important things that, we want to work with you and we want to support what you want to do as well. So if you just have open communication with your healthcare provider and say, you know what, I'm thinking of taking this. Are there any interactions with Revlimid, which is the maintenance treatment? Do you think that it's going to cause any problems? Often, I can't tell you if a naturopathic medication will work or not. My job is just to ensure that it doesn't interfere with the current treatment and doesn't cause you any big side effects. So as long as there's no big side effects, we're happy for people to potentially be on concurrently Revlimid and naturopathic medicine. But one of the most important things is that A, you tell your healthcare provider, and B is that, we just do a check to make sure that it's safe.
Okay, great. Next question has to do with the M protein count, so the monoclonal protein count. After a transplant, is there like a key number for that protein count to get to? Like, should it go back down to 0 or not? Or what are we looking for in terms of results?
All right, so it depends on what you started off with, right? So if you started off with an M protein of 80 and you're down to 8, that's a fantastic response. But let's say if you started off at 8 and you're still at 8, that response may not be quite as good. So there's not an absolute number. We often look at how much it's reduced compared to what you started off with. But one of the things I want to really add in is that, even post-transplant, you may still have an M protein, but the beautiful thing is that with maintenance treatment, it will continue to hopefully go down. So that number that you get post-transplant, is not just that number that will stay with you forever. If you choose to go on maintenance therapy, and again, it has some side effects, so there is a conversation, that number may further go down and the response will get better and better.
Awesome. So we'll just do 2 more questions. The first one here I have is how long does it take for for new therapies to make their way from the US to Canada?
So again, it's variable. One of the things I just want to say is that we actually have exceptional access to therapies right now in Canada. The government has been extremely gracious in terms of giving us access to therapies like daratumumab, Kyprolis, lenalidomide. So we do have access to a lot of good therapies. There's also a lot of therapies through that may be eligible through a clinical trial as well. So I think, for the most part, we actually have a pretty good number of therapies. In terms of new therapies getting approved, again, those are things that are looked at a national level, and usually if the clinical trials have shown a fantastic response, then the therapies with approval move pretty quickly within Canada as well.
Awesome. So the last question, actually, before we get to the last question, there's just a clarification someone is asking. Someone's asking, so just to understand, melphalan is the high-dose chemotherapy, correct?
You got it, exactly. So melphalan is the high-dose chemotherapy, and the whole reason we've done the stem cell transplant is so we can give you that high-dose melphalan.
Awesome. And so let's end off with this question. And so someone is just asking, what's the longest time you've heard of someone living with myeloma? Now, before you answer this question, I'm sure you get it all the time. If I can just share something with you guys, with this job, I meet a lot of different patients, during live events throughout the country, and also during our national conference that we have every year. And I've met patients who have been living with myeloma for over 20 years, and I'm sure you have as well. So if you can just shed some light on your experience with that. Oh, hello. 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 Oh, so we seem to have lost the connection here. Okay, well, I guess we've lost audio connection with Dr. Mian, and the webinar was over anyways. So I'd like to thank everyone again for joining us tonight at this webinar. Just a reminder that it was recorded. And it is available on our YouTube channel. So just be on the lookout for the recording. It'll be added probably tomorrow or the latest on Monday. And yeah, if you have any questions, you all have my email address. You should have received reminders about the webinar and all that stuff by email. So please do not hesitate to write to me to let me know what you thought. And if you have trouble finding the recording, let me know.
And sorry, Gabriel, I got disconnected there for a second.
Oh, okay. So you're back. Awesome.
Yeah, I'm back. I don't know what happened. I got disconnected there for a second. And so, sorry, you just to end that question, you had mentioned did you tell them about the longest patient that you had?
Yeah, so for me, it was, I believe it was 25 years. I met someone about, it was last summer, I met a patient who's had myeloma for 25 years and has had 2 transplants, and it's lasted for 25 years.
And again, those stories are exceptional, but, in my practice, I think the patient that I have who's had the myeloma for the longest is someone who got diagnosed in 1998. And again, similarly, I've had patients with 1 transplant and with that really old induction chemotherapy called VAD, who've had a 10+ year response. So there's definitely exceptions, but there's fantastic therapy in the 2nd, 3rd, 4th, 5th line for myeloma now. So the future actually looks really bright for myeloma. I just wanted to thank everyone really for joining in and taking out the time, and hopefully I was able to answer some questions, and hopefully everyone enjoyed it. So thank you so much for the opportunity.
Thanks, Dr. Mian. You were amazing. We're getting a lot of great comments here on the question board, thanking you for such a great webinar. And so thank you for taking the time tonight out of your busy schedule to do this for us, and have a great evening.
Take care. Bye-bye.
Bye-bye.